We will now shift our gears to begin our discussion on thyroid pathology. Knowing the signs and symptoms of hypothyroidism and hyperthyroidism is very important for the USMLE, and you can remember these symptoms easily by knowing that hypothyroidism is associated with down or low symptoms, and hyperthyroidism is the opposite and is characterized by more active or hyper symptoms. Hypothyroidism is associated with cold intolerance, weight gain, despite having a decreased appetite, lethargy, and fatigue. You also get decreased GI motility, leading to constipation. One will also see diminished or hypoactive reflexes. Classically, the terms delayed relaxation of the deep tendon reflexes is what one would see on the exam. Also, bradycardia might be present. And lastly, these patients tend to have dry skin and brittle hair. Contrast this with hyperthyroidism, where we have intolerance to heat and weight loss, despite increased appetite. These patients tend to be hyperactive, and this is reflected by their symptoms of diarrhea, hyperactive reflexes, and tachycardia. Do you remember what is the mechanism behind tachycardia and hyperthyroidism? The answer is increased expression of beta-1 receptors in the heart, and this can predispose patients to arrhythmias such as atrial fibrillation and tachycardia. Also, in contrast to hypothyroid patients, hyperthyroid patients tend to have warm, moist skin. Now I'm going to focus on some additional features of these disorders, starting with myxedema. So what exactly is myxedema? Well, it's a type of non-pitting edema that is due to increased deposition of glycosaminoglycans in the skin. Specifically, it is hyaluronic acid that is deposited. That may seem like a nitpicky detail, but it is a testable fact. Myxedema is typically seen in hypothyroidism. However, if it occurs in the tibia, this is often associated with Graves' disease, a specific cause of hyperthyroidism. This type of myxedema on the shins is known as pretibial myxedema. In hyperthyroid patients, one might also have increased CK levels that might reflect muscle breakdown. Also, patients are emotionally labile and may go through phases of euphoria, depression, and delusions. Alright, if you reviewed the physiology section, then you should be able to tell me the difference between hyper and hypothyroid based on a patient's labs. One lab result that you can look for is the level of free T4. So what would you expect it to be in the setting of hyperthyroidism? Right, it should be high because you're making too much, while in hypothyroidism it should be low because you're making too little. You can also measure TSH levels. And if you recall, TSH is our thyroid stimulating hormone, which increases when your body needs more thyroid hormone to be made. So what would you expect the TSH levels to be in hyperthyroidism? Right, they'll be low because your body is making a lot of thyroid hormone, which exerts a negative feedback on the release of TSH. Meanwhile, in hypothyroidism, the levels will be high because your body is trying to stimulate the production of T4. However, where it might get a little tricky is when you are trying to diagnose a patient with hypothyroidism and you have both low T4 and low TSH. So what could be going on here? Well, in this case, this could suggest a problem at the level of the central nervous system due to a, for example, decrease in the release of TRH from the hypothalamus. As a result, you don't have the stimulus to produce TSH to stimulate the thyroid gland to produce more hormone. There are many different causes of hypothyroidism. The most common one, and the most important one to know, is Hashimoto's thyroiditis. The mechanism of this disease is autoimmune. The names of the antibodies associated with Hashimoto's thyroiditis, and the ones that you will be tested on, include TPO or anti-thyroperoxidase, and antimicrosomal antibodies. Also, we have antithyroglobulin and antifollicular cell antibodies. There's a minor side note, and that is that antithyroid peroxidase antibodies can also be seen in Graves' disease, which is a cause of hyperthyroidism that we'll discuss in a few minutes. But more commonly, they are associated with Hashimoto's thyroiditis. Do you know which LA type is associated with Hashimoto's? HLA-DR5. Additionally, a really important thing to keep in mind is that these patients are at elevated risk for developing non-Hodgkin's lymphoma, specifically of the thyroid. Now you might be thinking, why is it important to know all that detail? Well, the boards can set you up with a question in which you have a patient who clearly has hypothyroidism, given the history and physical exam and lab findings. But the question might be, this patient is at increased risk for which cancer? And now you know it's non-Hodgkin's lymphoma of the thyroid. It is worth noting that although Hashimoto's is the cause of hypothyroidism, very early in the disease you might see a transient hyperthyroid period, and this is due to damage of the thyroid follicles, which causes release of thyroid hormone. Hashimoto's, as you remember, is an autoimmune disease, so it is characterized by immune cell infiltration and damage to the gland itself. Note, in this image on the left, we see heavy lymphocyte infiltrate. The image on the right shows Hürthle cells, which are unique to this condition and are enlarged epithelial cells with excess eosinophilic cytoplasm. Though they may appear to look like plasma cells, they're actually not. We now turn to a congenital form of hypothyroidism called cretinism. This is caused by a lack of thyroid hormone during gestation. Remember that the fetus is dependent on maternal thyroid hormone because it doesn't produce significant amounts itself. As you may recall, thyroid hormone is necessary for bone growth and brain maturation, so both of these processes are compromised, and additional clinical findings include potbelly, pale, protruding umbilicus, and protuberant tongue. Cretinism is usually caused by maternal hypothyroidism, and the mother might be hypothyroid because she is not getting enough iodine in her diet. Or if she is already hypothyroid, she may not be taking her thyroid supplements. Other causes of cretinism include failure of the thyroid to develop, and this is known as thyroid dysgenesis. Another form of hypothyroidism includes subacute thyroiditis, also known as Quervain's thyroiditis. The distinguishing feature of subacute thyroiditis is that the thyroid is quite painful and tender. This disease typically occurs following a flu-like illness and is self-limited, meaning that if we let it run its course, it will not need any specific treatment. Other findings include an elevated ESR, jaw pain, and granulomatous inflammation on histology. Like Hashimoto's disease, subacute thyroiditis may involve a brief period of hyperthyroidism at the beginning of the disease onset. Lastly, Rydell's thyroiditis is a disease in which thyroid tissue itself is replaced by fibrous tissue, so there is not enough follicular cells remaining to produce the required hormone levels. On physical exam, you will find a fixed, hard, or rock-like gland, and it will not be painful. Some other less common causes of hypothyroidism in the Western world include the following: dietary iodine deficiency, goitrogens, which are substances that interfere with iodine uptake and suppress thyroid function, and an example of this would be lithium, which is used to treat bipolar disorder. There's also the Wolff-Chaikoff effect, which refers to a transient decrease in thyroid hormone levels as a result of excess iodine ingestion. And lastly, painless thyroiditis, which is also known as subacute lymphocytic thyroiditis, is a subtype of Hashimoto's thyroiditis. One form of this that you may be tested on is known as postpartum thyroiditis. Now let's look at the causes of hyperthyroidism. Toxic multinodular goiter is characterized by focal patches of hyperfunctioning follicular cells that are overproducing thyroid hormone just on their own. They are making the hormone regardless of the TSH levels. This is because the underlying cause is a gain-of-function mutation in the TSH receptor. Of note, when you palpate this person's thyroid, it will be enlarged with multiple distinct nodules, hence the name multinodular. If you were to do a thyroid scan to detect areas of activity, you'd see increased uptake of radioactive iodine in multiple distinct foci or patchy areas of uptake. The Jode-Basedow phenomenon describes a situation in which patients with iodine deficiency goiters actually experience thyrotoxicosis if the iodine deficiency is corrected too rapidly. The thyrotoxicosis in this case has similar clinical features to that observed in patients with hyperthyroid disorders. Another autoimmune disease related to the thyroid is Graves' disease, but in this case, patients become hyperthyroid. The reason for this is the presence of autoantibodies against the TSH receptor that bind to and stimulate this receptor. Now, we already discussed the general features of hyperthyroidism, but Graves' disease is unique in that it has some interesting additional physical findings. The first is exophthalmos. This is known as Graves' ophthalmopathy and is characteristically bilateral, which helps you differentiate it from other causes of proptosis or bulging of the eyes. Do you know why this occurs? This is due to excess deposition of glycosaminoglycans by fibroblasts. there's a specific type that I mentioned earlier that is especially prominent. Do you recall what it was? Right, hyaluronic acid. Another physical exam finding is lid lag. This is when the person is resting their eyes. In these patients, you'll see the sclera here, even with their eyes at rest. Another consequence of glycosaminoglycan deposition that we mentioned before that is seen in Graves' disease is pretibial myxedema. Thyrotoxicosis is an increase in thyroid hormones that can be very severe, as in the case of thyroid storm. This is a complication of Graves' disease as well as other hyperthyroid disorders, where a massive release of thyroid hormones induced by stress causes a catecholamine surge, which can lead to cardiac arrhythmias and potentially death. Okay, flash quiz. Graves' disease is an example of what type of hypersensitivity reaction? Type 1, 2, 3, or 4? If you remember, the mechanism of Graves' disease is through an anti-TSH IgG antibody that binds directly to the TSH receptor, and this antibody-antigen binding is a type 2 reaction. Please go back to the immunology section and review the other types of hypersensitivity reactions later. The boards love to test you on this concept. They'll present a case in which you'll have to make a diagnosis and then determine which hypersensitivity reaction is to blame for causing that illness.